Value-based care has a longer history than some people might realize. First conceived in 1967 and focused on sick children, the term value-based care was coined only in 2005. Now, 20 years later, value-based care arrangements cover almost half of health plan payments. My guest today helps practices adopt and use value-based care programs, and she's going to help us break down how you can as well. I'm Carl White, principal at Market Advisory Group, which is a healthcare marketing agency, and I'm also the host of Practice Care. The mission for both is the same, and that's to help private practice owners stay private. It's usually what they want, and care is better, I think at least, when it's the providers of care who are owning the practice, because then all decisions that have to get made, clinical, business, whatever they may be, are made by those who are also caring for patients. So we can rest assured that the needs of patients always stay top of mind. My guest today is Dr. Shannon Decker. Shannon is the founder and CEO of VBC1, a consulting firm that partners with physician groups, health plans, and vendors to optimize value-based care performance. With over 25 years of experience, including 17 in risk adjustment, quality, and Medicare, she brings deep expertise in healthcare strategy, analytics, and operations. A published author and national speaker, Dr. Decker currently serves as a RISE, R-I-S-E, all caps fellow, and on the faculty of Capella University. This is a cool topic. Thanks for coming on to Practice Care and helping us take something that seemingly has a long history that I'm going to guess is pretty well misunderstood. So thanks for doing so.
Thanks so much for having me. Excited to be here.
Yeah, absolutely. So regular listeners will know where I'm going to start. It's not about value-based care. It's about you. That was a pretty short bio that I read. So help us, get to know you a bit better, VBC1 a bit better.
Sure. Like I said, really glad to be here. I've worked in healthcare for more than 20 years. Started working with an organization where we were looking to mitigate lifestyle choice and help people appreciate their lives and participate in their lives more fully.
Okay.
That moved into healthcare. So working for a large insurance company, got to know Medicare Advantage, and then that quickly evolved into working in something called risk adjustment. And so managed risk adjustment end to end for a health plan, moved into later working for risk-bearing provider groups. Some of the big names that if you said them, I probably am acquainted
Okay.
with them for several years, and then had an opportunity to go out on my own. And so in 22, started VBC1. We provide fractional support to provider groups that need operations help with participating in these risk-bearing contracts. And so if you think you don't have the infrastructure, you don't quite understand, we're there to support you and to advocate on your behalf. And then also we have the team, we can do all of it or just a little. So we pride ourselves in being that Goldilocks solution. We can fit in wherever you need us.
Got it. Very good. Okay, great. So I want to start with just sort of definition of terms. What is value-based care and how does it compare to the fee-for-service payment model? Let's just make sure as we all listen to this, we're all thinking about it in a common way.
Sure. So when I think about fee for service, a lot of us are most familiar with that, I would think. I know I was growing up. You got sick, you went to the doctor, you were seen, you were treated, prescription or what have you, and you left.
Mhm.
The difference between value-based care is that it's a paradigm shift, is how I like to think of it.
Mhm.
Rather than being reactive and reacting to symptoms, it's being proactive. And
Okay.
so how do you get ahead of the things that we know, right? People have lived long enough, and I did not know that the term came out in 1967. So you've added to my education.
With sick kids, yeah, with sick children, that was the start. Yeah.
Yes.
Yeah.
But how do you get ahead of things that we know are going to typically and traditionally happen to people in our country? Because we know, right? We know from experience that a large portion are going to have diabetes or, end up getting breast cancer. And so if we can get ahead of that and be preventative and
Mhm.
be proactive, we can help people live longer, healthier, and hopefully happier lives.
So let me say my understanding. You tell me if I've got it or correct me where I'm wrong. So fee for service, you get sick, you show up, you get treated, and there's the costs. Insurance pays for some, you pay the rest, whatever it is. So it's like it's activity. right? The provider side is providing activity. The value-based care says for this disease state, diabetes, we will pay you, physician group entity, X amount of dollars per
Yes.
year. And you treat it. And whatever's left, if it was $100 for the year and it would you charged 80, that extra 20, we split.
Yes.
Is that pretty much it?
It is because again, like I said, we know the activities that are associated with a diabetic with, with complications.
Mm-hmm.
And so we know how much the care is going to cost for that.
Mm-hmm.
So if the opportunity, and it's not about denying care, it's about how can we ensure that those patients, right, are taking part in their life,
Mm-hmm.
and making choices that would help them stay healthier, getting their eye exams every year, making
Mm-hmm.
sure that they're keeping their A1Cs in check,
Mm-hmm.
making sure that they're participating with their kidney function testing. And so
Mm-hmm.
if we're able to keep them healthier longer, the idea is that they won't need the things that we would expect if they are left to go unchecked. And so then you're right, there is a savings there. And it goes even beyond that. I didn't get into this, but
Mm-hmm.
one of the things that I think will resonate with the audience, I speak to a lot of physicians or speak with them, and we talk about just how their practice and their patient panels have changed and
Mm-hmm.
people living longer, but not necessarily healthier. And there aren't enough physicians
Mm-hmm.
help all these people, right? And so medicine has done great things through its medications, through its treatments to help people live longer,
Mm-hmm.
but again, not necessarily healthier. And so how do we then also to make sure that we're using physicians in a way that best uses their license and their education? And so again, so that they can help the people that they need to help.
Yeah.
Uh, there's other things that we can put in place to improve health. Those are the things that we want to do.
So I think of it as you have a budget. You have $1,000 in the year to treat Carl for his diabetes. Spend it as you will. I mean, I'm sure there's of course there's guardrails, but get creative. And so what you're saying is, let's help Carl live a better life day to day, so
Yeah.
that he stays healthier, and then everybody wins. Is that the kind of that's?
In a nutshell, yes. And,
Mhm.
teach Carl to know what foods he should be eating and teach Carl that he too is an actor in this. And
Mhm.
so he should, be out exercising and
Mhm.
eating healthier and taking his medications when he should be. And
Okay.
we can teach him those types of behaviors, making sure that he shows up for his preventative exams as opposed to, in the ER in the middle of the night because he didn't listen, didn't take his medications and those types of things.
Yeah. I mean, it sounds, tackle a problem early, you're going to tackle it faster and cheaper and better, and it's going to be easier on everybody. Let it linger as sort of a generic statement. But what are some things to consider when let's put into your language, tackling risks? Like one thing I could think of is, what if Carl is just a terrible patient, doesn't show up, nods
Yeah.
his head, you're right, I'll stop eating chocolate bars and eat more fruit, than I don't anyway. Like I'm not there, you're not with, so there's like what are sort of the categories of risk? Why isn't this more prevalent? I mean, well, I'll come back to that, but like, how do you think about this as a practice?
Well, you said patient and agree with you. When I think about risk arrangements, I'm always looking at what are the three levers that I can push on
Hmm.
that I know are important to performing in risk. And one is the patient. How do
Hmm.
you to be compliant? And I can talk about that here in a
Hmm.
moment. The physician. So how can you equip the physician with the things that they need, the knowledge that they need in order to perform well,
Hmm.
risk, and then the tools and technology, right, to help support that. So the screening devices, maybe it's documentation tools that they're using to ensure that they're capturing the,
Hmm.
chronicity of that patient.
Hmm.
When it comes to patients, there's lots of ways I think that you can influence them, and that's my background too, is in the
Okay.
social behavioral sciences. So I'm a PhD,
Hmm.
and when we think about adults, I think one of the things that I found most powerful in working with patients and getting them to go along with what they need to is number one, you don't ask a couch potato to get up off the couch and run a marathon. And so to tell them to give up all their favorite foods is going to be very difficult, right? Like how many of us start with a New Year's resolution and we depart from it very quickly.
I
You
think
know,
that's all of us. Yeah, I think it's
exactly.
about everybody.
Myself included.
Yeah.
Exactly.
Sounds great on December 31st. I'm so friggin' revved up. And then, yeah.
But choose small steps, right? So even small steps can get them further down the path
Hmm.
than or than again, you don't run the marathon, but you get up off the couch and you walk to the TV to change the channel. And so small behavior changes like that can make a difference.
Hmm.
And I think finding, opportunities where, they're willing to maybe change a couple things. And it could even be, just making sure that they're wearing their glucose monitor or that they're checking their A1C or, hey, schedule your eye exam once a year. I mean,
Mm.
those little tests or those little tactics will
Mm.
get them further along. And the thing about the human animal is that once you're rewarded and you experience that reinforcement, hey, I did a good thing, they're more willing to take on other things. Well, that
Mm.
wasn't so hard. So
Okay.
walking on TV to change the channel wasn't so hard. Maybe next time I'll walk out to the mailbox and so on and so forth. And so you
Hmm.
build on those behaviors and try to get it better behavior.
Okay. So that's the patient side. What about, you said, the physician side? There was patient, physician, and systems or tools,
Yes.
and yeah.
No, great point. I think, with this paradigm shift and what I hear a lot from our physicians that we speak with is that, and I'm going to say it and sound negative here for a moment, but it's an administrative burden, and I understand that. But the way I think it's been framed in a way in the past with physicians that it's difficult or that you have to write everything down in your notes about that patient. And what I encourage physicians to do is make sure that it works within your workflow. You have a
Hmm.
lot of patients to see, but record the things that are most important for the patient that we need to know. And so if that patient has diabetes, anything that enters into your mind when you're evaluating that patient, you want to make sure that you're documenting in the record. And so if the patient has diabetes, right, you want to make sure that you are identifying that in the record. And
Hmm.
that's part of the treatment and plan when that patient leaves your office, so that it becomes part of the record. And I think one of the areas too, a lot of times it's not necessarily the physician, when we talk about paperwork, it's making sure that that information then gets onto the bodies that need to know more about that patient and their
Hmm.
chronicity. And so ensuring that your billers, right, are adding those to the bill, that those notes are being shared as appropriate. But beyond that administrative piece, I think, the important piece is, again, having that connection with the patient and looking full circle, right, at everything that could be going on in the patient's life. I know in doing some of my own research, when I interview physicians, they talk about they went to medical school because they want to help people,
Hmm.
and then they get into the practice of medicine, and a lot of times it's not what they had signed on for or what they had expected, but they still try to get at, right, how can I make things better for patients? And I think that's the thing that you need to remember. We know again, and I use diabetes a lot as an example, but we know that eyesight is quickly impacted, right? Especially with a diabetic that's not controlled.
Hmm.
And so getting your eye exam every year, right, will make a difference in that patient's life. And so it does give physicians, and when I've talked to physicians that we've worked with in the past, they'll say to me, I feel like I had a better visit with my patient because I better understood, what their needs were, what their conditions were. And so it does give them an opportunity to get to know that patient a little bit more than, the 5 seconds that the patient, and I don't mean to diminish, I'm looking at surveys and reflecting on that data.
Sure.
But when the patient comes in the office, right, it gives them a little bit more time and a little bit more perspective in
Hmm.
how to look at that patient.
Yeah. Yeah. And I wanted to ask you, like, do the mechanics of you think about, you get 7 to 12 minutes, with your patient.
Yes.
So does that lengthen? Is just the focus change? Because you could see, I mean, I could
Yes.
imagine a physician hearing this for the first time and go, "Oh my God, we
You
took
want me to do
everything I
what?
know how to do and we just blew it up,
Yes.
including how it's all organized, and now we have to rebuild it." And one of them is, so how much time do I spend with my patients now? Even though my mission, yes, my spirit is to help people. So does that, like, give us some like just like a couple of snapshots of before and after, like just day to day.
You bring up a really good point, and that's the third lever that you
Hmm.
can put on, and that's
Okay.
in technology. And when I say tools and technology, it doesn't have to be fancy systems. It can
Hmm.
be paper.
Hmm.
It can be, the pencil was once thought of great technology.
Sure.
So it can be simple things. And I think of it in the same way that I think about your patient, small steps, baby
Hmm.
steps, if you will. So it could be things like, pulling the patient's chart ahead of time and then having your receptionist or the medical assistant in your office have them put a cover sheet with the main conditions that need to be addressed.
Mm.
It could be that you flag all your diabetics in the month of March, and you're going to call them all and remind them that they need to come in and get their eye exam. It can be little steps like that that can make
Hmm.
a difference. There are great tools and technology out there. There's ambient devices that can listen in and translate or transcribe notes for you. We've worked with physicians where even just setting up within their existing EMR different screenings, right? Like make sure that you're doing the PHQ-2 and the PHQ-9 for depression screening for all your patients, because
Mm.
know that, right? Mental health is something that is oftentimes goes undiagnosed. And so we want to make sure that we're paying attention to that. There's lots of great systems out there that you can invest in
Hmm.
if that's something that you want to do. But I think that's one of the things that I've done, and that's why I decided to start my own company. And I know we'll talk more about this later, but
Yeah.
where are there opportunities in the system that you currently have?
Hmm.
You put yourself right to intersect with that system
Right.
and make it so that it's not so difficult.
Hmm.
There's easy ways that you can find ways to insert yourself to be
Right.
active. And again, it can be simple things like a handwritten post-it note on a chart that, hey, that patient is a smoker. Ask them if they smoke, if they cough every morning. Because if they do, even if they quit, right? That's something that should be documented in their medical record because we know what's going to show up later in their health history.
Got it. So part of it is okay. So a couple questions about the economics of
Mhm.
this, one very sort of tangible and the other not so much. So I can't think of a way to ask this other than in a crass way. So do the payments, the per disease state payments, do they support some of the stuff? Like, are they realistic? Because as you were talking about, have an MA do this, have a reception do it, spend a few more minutes here or there.
Yes,
I bet you 10 out of 10 physicians would say, I don't have the staff for that, and I don't have time for that. So,
yeah,
but if the money were there, you could rejigger some things and maybe, you know what I mean? Like, so does it support that? Or go get this device, or you know what I mean?
it does. So I think that just to take a step back, I think you look at where you're at, right?
Hmm.
Where you're at and what you can invest, and you look at what you can do with what you have.
Hmm.
And even if you don't have an MA, right? Or even if you don't have those extenders in your office, there's other things that you could potentially do.
Hmm.
As far as the payments, yes. And that's where that comes in with, working with CMS if you're an ACO program, or working with health plans if you're taking Medicare Advantage patients, speaking with them about those contracts, and then also getting some of that reimbursement because we know the health plans are reimbursed for the chronicity of patients that
Hmm.
are part of the Medicare Advantage program and Medicaid and commercial for that matter. The models are slightly different,
Hmm.
but they're all being reimbursed for taking the risk of those members. And the thing is if you as a physician are able to save monies, right, and better care, I mean, who else, right? You're
Yeah.
going to do a far better job than some administrative health plan. If you're able to direct the care and then provide savings as well as improvement in life for that patient,
Hmm.
that patient then becomes a longer member or beneficiary of that health plan. There are opportunities to share in those funds, and it's knowing how to do
Yeah.
that negotiation,
Yeah.
knowing how to have those conversations, and
Oh,
we do that. I mean, we do that too. We read
okay.
contracts, we advocate on the behalf of physicians. We let them know honestly where their infrastructure is and what they can take risk on, and so
Hmm.
on.
Yeah, I imagine a decent chunk of what you do with clients is, today your practice looks like this, and tomorrow it's going to look like that. we will
Yeah,
help you migrate from one to the other because there's daily changes, bigger changes. It's like it's a lot to take on. So yeah, is that fair?
it is. And, just looking at the landscape, I work with a lot of different people across the country. The mantra was that everyone was going to be in a risk-bearing arrangement by 2030. And so it's not going away. And we
Mm-hmm.
can already see consolidation of health plans. There's a
Mm-hmm.
lot of plans maybe that aren't offered any longer. You may see too consolidation of health networks, hospitals, and
Oh,
others
yes.
coming together. So, definitely the landscape is shifting. And again, just like with disease prevention, with this, I would want to be ahead of it,
Mm-hmm.
and guide my future as
Yeah.
opposed to, drug along.
The other question I have, it's more kind of abstract, and it's when you look at this model, value-based care, here's a pot of money, I'm saying this very crassly. Here's a pot of money. This is your budget to treat that patient. Um, if there's savings at the end, we share that. I guess if they go over, I don't know what, you don't have to explain what, but that's not good. Um, it can make it feel like, efficiency is what's driving healthcare decisions for back to me as a patient, rather than whatever's going on and, my needs are different. And nobody likes to think about efficiency as maybe in competition with care, um, because cutting corners, da 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 da. So how do you? I can't be the first person. You're already nodding your head. For those who will watch this on YouTube, a very small fraction of you. So you're already nodding. Like clearly, you've heard this before.
Yeah.
Respond to that. Talk about it. Just because you can see it. Like even if it's not true, you can. It's a logical point. So not that doesn't make it correct, but so yeah. Talk about it and respond to it.
It's a slippery slope, and we do see bad actors that want
Okay.
to, I think they're bad actors when they
Mm-hmm.
want to capitalize on efficiency, where they're denying services or they're forcing patients to appeal things. And the thing is the doctor that's in care of that patient should have the authority for what happens for that patient. And so CMS and others have seen that. There's a lot of rules that have been made to make sure that patients can get the care that they need, that, you can't just deny for the sake of denying. We were seeing a lot where every MRI, right? And I'm sure your audience has had that experience and they're like, yep. And where the patient couldn't go and get an MRI, even though that's what you knew what they needed, they were making
Mm,
an X-ray first, or you had to prove it, or for certain medications, right? Trying to keep patients on formulary. It's not that
mm,
patients can't exist, uh, but I think it's a couple of things. So if you're a provider and you're in those contracts, I think as a provider, you do what's right by the patient. If
mhm,
you do what's right by the patient, it's always going to come out. And there's lots of rules around making sure that patients get the things that they need. If they change health insurance, they're allowed to stay on their medication. I think it's 6 months if
mm,
they plan. So there's a lot of rules that are put in place to provide protections to make sure that care isn't detrimental in the name of efficiency,
mm,
that patient. And so as the physician, you went to medical school, you provide for the patient in the way that you know how and is appropriate.
right.
And then if you're participating in these contracts, and that's the thing, make sure that, there are carve outs, there are certain things that you can guide against if you do have catastrophic
Okay.
expenses that are associated with that patient, so that you're not taking that on the chin, so to speak. That can happen. When I've
Hmm.
seen books that are written that way, there are opportunities to negotiate those with the health plan so that you can participate, you can be paid for the work that you're doing,
Hmm.
copay, right, or the fee for service copay that you're getting for patient A and patient B, but patient B is much more sickly, and you
Hmm.
have to provide your knowledge and expertise to that patient, and you have to spend longer with them. You have an opportunity to actually be paid back, right, for that work and for that expertise that you're using. But that's the thing, is that you want to make sure that you're negotiating contracts in a way that are making it so that you can practice in a way in which you feel comfortable.
Right. With the overriding goal of, well, the patients to be healthier.
100%.
I mean, it's hard to
Believer.
argue with that as the goal. And
Yeah.
it's pretty fair to say that, if we wait for patients to come to us, fee for service,
Yeah.
there's a pretty good chance they're not going to come when I would have told them to come had I known. Is that?
Exactly. And,
Mm,
no, exactly. I think that, I know it sounds maybe Pollyanna, but I do believe that, when you do the right thing,
mhm,
uh, right things will follow. And so again, do what's right by your patients.
mhm,
But if you're getting into those contracts, make sure that you know what's expected of you. Make
sure.
sure that you know what you're agreeing to so that
Mhm,
you don't get into a situation. Because unfortunately, there are folks out there, or there are still holdovers with folks thinking that they're doing a good job. I honestly think that they think that, they're doing the right thing, they're saving money because most people should get an x-ray or try physical therapy before going and getting an MRI or
mhm,
before getting surgery, or they should go to an ASC, right, for that knee surgery or that shoulder surgery. But that's the thing is that, those folks that are making those decisions, they're blanket, universal, generalized decisions, and we can do better, um, especially with the technology and what we know about patients. And then
mhm.
also too, clinicians know, they know their patients better, and so they know what's appropriate care. And so I
Yeah,
think for maintaining that clinical voice in those discussions is important.
got it. Okay, cool. Can private practices participate in this, or is this just something for very large systems, very large entities?
I work with private practices
Great.
that
Okay. I was hoping you'd
do.
say that.
We work with independent physicians, so absolutely, and more are getting involved. There are some that are connecting with other private practices in their area,
Mhm,
looking for these contracts, but even on their own, there's opportunities to participate. You can participate as an ACO, you can participate with Medicare Advantage, and with these health plans, it'll really depend on panel size,
mhm,
but there is an opportunity to get involved. And it's having the discussion with health plans or reaching out to someone like me who can help make those introductions
mhm.
to get on your way. And then we evaluate, where your practice is and what you would need to do to be successful based on the risk that you're taking. There's different types of risks too. There's shared risk, there's global risk. And so knowing what's right for you.
Yeah. ACO, Accountable Care Organization, just for you, what do
Oh,
you band together as a few different practices or what? Like it's accountable
yeah.
care. Like it's so many things in life are named with names that don't help you know what it is. So what is that? And how
Health,
would a private practice get involved in
yes.
that? Yeah.
Healthcare is definitely one of those places where we have our own language, and especially in in insurance and in value-based care, lots of acronyms.
Lots of jargon. Marketing too. My God, most of the marketing terms. Anyway, yes. So yeah, just talk a
So
little bit more about how those different ways that a private practice could participate.
So if you're part of, if you're a private practice, you may be participating with physician organizations within your area, and those would be places that you could potentially look. So it really depends on your panel size. If you aren't very large, you can band together with other physicians that might have a similar interest as you,
Okay.
and so then form a loose construction, which, having a larger panel size, you would have the opportunity then to talk with health plans and secure a contract for yourselves.
Okay.
Uh, and, those are opportunities to talk about the contract language there as well, as to how you want to interact with one another.
Mhm.
Um, Groups that I've worked with in the past, so IPAs, the physician offices agreed, right, to a certain degree to participate with some things, but they didn't give up all their rights. And I've had physicians that have participated in several IPAs, so they weren't
What is
necessarily,
IPA?
thank you, Independent Physician Association.
Okay.
And so that's where independent physicians come together for the purpose of having more collective strength. And so they're able to negotiate contracts, potentially with their panel sizes. Maybe they can negotiate prices on technology.
Hmm.
So lots of things that you can do with that.
Hmm.
And again, that gives you an opportunity to decide what you want to, how you want to participate, what the rules of the game are going to be, or how you're going to play, if you will.
Hmm.
And then, you can decide based on that. And so that's how I've seen physicians come together, private practices come together. But I've had private practices that are quite substantial as well and be able to command their own contracts too,
Okay.
with primary care and with specialty physicians too.
Okay.
And then the other way that you can participate is participating directly with Medicare, and that's through any of the ACO programs or with the exchange. The ACO would be accountable care organizations.
Hmm.
Similar, it takes out the health plan, and you are contracting directly with CMS, and there's an opportunity to choose what type of risk pool you want to be in. But again, lots of decisions to be made,
Hmm.
but with good reflection. Don't jump ahead and look at the end of the contract and what you might get from it, but truly understand and appreciate where your practice is and
Hmm.
how you might participate and be successful.
Yeah. And even if or when you do look at the financial side, I guess my own personal piece of it, because it's not unique to this scenario, is give yourself a few years to realize that number that looks so promising. This would be a whole new thing. It just
Yeah.
takes time. There's learning that it's hard to make go faster. You just have to live with it for a while and see how things can improve. Micro change, it's just like you were talking about with the hypothetical patient. Walk to the TV instead of, and you take these micro changes and stack them on top of each other. Eventually, they can become pretty substantial in totality.
Habit stacking. Yep.
Exactly. Yeah. Um, so why should they just do this on their own? This is a very biased question to you. I mean, what do you think? I mean, when I'm
Yeah.
asked about marketing, like anything you think you could do on your own, you should try it. I guess you should try it, but just make sure that you've got enough time and tools and talent to do it well. This just seems like it'd be a minefield. I don't know.
It can be. It absolutely can be. Really understand what you're getting into and what you're agreeing to. Even some of the things that they'll add into your contract, the health plans have challenges with.
Mm,
You just worked with a group, and I'll give you, for instance, we worked with a group, and the health plan said to them, well, you need to get to 4-star if you're going to participate in any of the shared savings. Well, the thing is the health plan had never gotten above, it was a 2.3, which is why I'm sure they're looking for physicians to partner with and make contracts with.
to raise their rating.
Yes. And then the area itself, just for that, geographic location was slightly above a 3. So it's not something to say, oh yeah, I can do that. There's a lot of work that's involved in that.
Mhm.
Um, there's a lot to these contracts, understanding attribution, again, understanding, do you have the ability to reach out to patients when they need their osteoporosis screening or they
Mhm.
need the mammogram or the colorectal cancer screening? Do you have partnerships with the specialty networks in your area to make sure that that patient can get in for their colorectal cancer screening? Or you have a backup plan.
Mhm.
You have a home lab that's sending an FOBT kit,
Mhm.
which would close the gap measure for the year. It would still allow you to be successful in your contract, but the colonoscopy, right, is the gold standard and would close that gap for you for 10 years.
Mhm.
So I think it's really having that awareness of where you are, and you are a phenomenal physician. And not that you couldn't go learn this stuff, but do you really want to? And then also too, I've seen things over the years that one might not expect. And so there's just things, right? And I'm sure that this is in every field that you come across through experience that you're like, and it makes you wonder, and you
Yeah.
might have come across that. No one wrote about that anywhere. It just comes through
What's an
experience.
example? Like a
Um,
crazy, I don't know, just
yes. So I'll share one. I worked with a physician group. They were seeing patients. It was a normal visit, 99213. It's typically the code that one would submit 213, the 1415 on the level of complexity of the office visit. It's often used for patients to come in and potentially get, say, an annual wellness exam. And we found, and this wasn't that long ago, and it was a very large national health plan. You would know the name in an instant, even if I showed you the logo. And they had these capitated arrangements with physicians that those visits were covered in their contract, and that the physicians would be paid what we call a per member per month fee. So
Capita, right.
instead of getting that copay, right, you get that per member per month fee for taking care of those patients. So their claims department was rejecting all those encounters. Well, those encounters were important because they carried, very important information about the patient. So information about what conditions and diagnoses the patient had,
Mm,
whether or not the patient had, certain measures closed that were part of their quality measures that the contracts,
right.
were held to. And so they were rejecting all those. And by doing some reconnaissance with the data, we were able to understand that they were doing that to our physician group, but it uncovered a much wider problem. They were doing it across the entire nation, across all their
An
risk.
insurance company was underpaying. I'm shocked.
Well, I know they
I've
weren't.
never heard that before. I thought it was the
Well,
opposite.
it wasn't that they were underpaying. What they were doing is they were rejecting the claim, because that's the thing, right? They were
They
rejecting the
were
claim
automatically rejected. I've never heard that before. Oh my
automatically
gosh.
because it was part of capitation.
Yeah.
So it was assumed that it was already paid as part of the PMPM. But what they were missing was all the clinical and quality data that's
Mhm.
needed for reporting for these risk contracts that these physicians that were in. So it was like the other side of the business didn't realize that there was important information there. And it
So
was
is it that
national,
they should have been accepting the claim and then paying, or just accepting it to get the data in?
accepting it to get the data, to know
Okay.
that
So they
the
rejected everything.
yes, and just basically kicked it out the door and never saw that, the doctor did assess that patient and noted that the patient had diabetes, or that, the doctor did again, order a mammogram, or that noted that, the
Yeah.
patient their statins. So all those measures that physicians are held
All the
accountable.
performance data. So at the end of the
Exactly.
year, Dr. X, you haven't been living up to the con. What do you mean? I get it. Yes.
Well, and I've sat in on those conversations where the doctor's like, "What are you talking about? I did that." Well,
Hmm.
there you go. It's
It's
not
not
shown.
documented.
Yeah. And
Oh.
plans have lag data. There's all sorts of things that happen. We've seen things where EMRs are not set up appropriately. And so a lot of times a way in which they're set up, and all EMRs are different, and whether or not you had someone help you with it, and
Hmm.
um, there's all ways in which it can get waylaid, but one thing that's general too is there's a number that's associated with your physician type, and CMS only recognizes certain ones for collecting risk and quality. And you have to make sure that your EMR is set up appropriately, because when you're sending in your data, some health plans will catch it, some won't, but you
Mm.
need someone to advocate for you and really understand how you're doing, what your data looks like, and then how it's getting, right? It's like operator. Did it make it? Did the message clearly make it all the way over to CMS? Or did it get dropped somewhere, either in your EMR, at the biller,
Right.
right? Or through the health plan? There's lots of different places that things can get hung up.
Well, and it's interesting is the game of operator. Yeah, the game of operator is no, whatever was said at the start is nowhere near what is heard at the end. So, oy.
Exactly.
Um, we have covered a lot of ground in not so much time. Is there anything you think we missed that we really, with the understanding this could be a 6 hour discussion? Is there anything you think we missed?
Um, earlier you started the conversation talking about, this podcast and is about keeping doctors, right, in private practice and
Yeah.
allowing them to practice medicine
Hmm.
and be independent. And I know that sometimes folks think that these contracts inhibit that. I don't think so. And
Hmm.
I do think that while you're doing that reporting, you're doing this work anyway. You're doing the best care for your patients. You just want to make sure that it's reported right in a way that's needed. And that's when I think that, you look to people that can help you
Hmm.
that type of work. But on top of it, I think of it as, you're being paid for the work that you're doing. And so earlier I mentioned, patient A might not need a lot of care. They're a healthy 30-year-old, they have a cold, they've come in, for a prescription, you give it to them, they're out the door. But then you have that patient that's that diabetic patient that you have to
Hmm.
spend time with. right? And so this allows you or gives you the opportunity to actually be remunerated, compensated for the good work that you're doing. And I think it allows you to work to top of license so that you have more monies available. That if you do want to put in, hire an extender or put in other things in your office to help you strengthen your practice, that there's opportunities there, more so than there would be with maintaining the fee-for-service model.
So does that even mean, just to get really sort of tactical? So take those two examples. Patient calls up, says, I need to come see you. I've got a cold. I'm otherwise healthy. Is that like a 5-minute appointment, but then the diabetic is maybe a 25-minute appointment, whereas today they're all pretty much 12-ish or whatever? Do you
Yeah,
see clients doing that, like tailoring their schedule to need?
I do. And I also see,
Hmm.
and I'm sure that a lot of your audience too, that you have the opportunity to use telehealth in those instances in some ways. Or, they have extenders in their office, so you don't
Hmm.
need to see the doctor, but you see the nurse practitioner,
Hmm.
or spend most of your visit with that person, and then the doctor signs off on anything that was evaluated during that time. So it does give you an opportunity, especially, I mentioned people are living longer, not necessarily healthier.
True.
So you have expanding patient panels.
Hmm.
You can't trade one for one like you do with fee for service. You're
Hmm.
not going to be able to do well by the patient, but also for yourself, right? Think about how many hours and the dependence on you being there and, trading widget for widget, if you will.
Yeah.
I think that value-based care contracts open that up so that not only patients, right, have a healthier, better life, but our physicians can too.
Fair enough. Very good. And then the final question I ask every guest is, the context is, we've caught listeners' attention. You've convinced them, they're excited, but it's a brand new concept, very new concept, and they just don't know where to get. They get paralyzed by, where do I start? So
Yeah.
what's something super simple they can do to, get off the starting line and get moving towards, down the path of, we are going to become a value-based care, you know, practice. Hmm.
Talk to your friends, understand those that are involved in it, talk to companies like mine,
Mhm.
talk to health plans where you're accepting insurance. There's the opportunities, to have those conversations. And then I would say, understand where you are, understand where your practice is. And again, that habit stacking, those baby
Mhm.
steps. And I always think of it as when I talk to clients, we talk about what's base case, what do you need to operate, what's better, and then what's best in class. And you may not be ready to run the value-based care marathon yet, but you can get up off the couch. And so
There you go.
someone like me or a health plan or a partner, but talk to someone and again, really understand where your practice is, where there's opportunities to grow and or even highlight things that you're doing great, and to bring that to the fore so that you can be successful.
So I'm going to break a rule, and I actually have one follow-on question. So, primary care practice, could I pick like one part of my panel and just test it
You
with that, but the rest stays the same? Or do I
you
have to like fully convert the whole practice in all patients?
Yeah, no, I love that. You could, and there are groups that do that. So I
Okay.
have worked with groups that just take risk on Medicare Advantage or
Okay.
just take risk with ACO, others that just focus on their Medicaid population.
Okay.
And we would talk about that. We would look specifically, because that's the thing too, especially with data the way it is today, you can look specifically at what panel where there's the greatest opportunities, or maybe where you're further along, right?
Mhm.
Halfway to the couch as opposed to
Right.
still on
Right.
that you can pick. And it's not as big of a lift.
I just think of like piloting things, trying them out, see how it goes, learn a lot along the way without, betting the whole practice on it. So,
Pilots are very popular. Health
yeah.
plans do them all the time. So
Yeah.
absolutely test the water.
Exactly. There you go. Perfect. Thank you. Dr. Shannon Decker with CEO of VBC One. Again, thank you for coming on Practice Care. Hugely interesting. I know we could fill hours. We're not going to, but thank you for coming on Practice Care and telling us all about it.
Thanks so much for having me.
Yes, and we've got some contact information for you. So those are going to go into the show notes for your episode. So anyone who's listening who wants to get a hold of Shannon now has another way to do so. Two quick points before we wrap up. Regular listeners know what these are. First, If you're like Shannon or us and you serve private practices, or if you're one yourself, either way, you've got some experience on the business side of private practice. And don't overthink what that is. You figured out something, you think it's simple and forgettable. I promise you, others are struggling with it. Come on Practice Care and share your knowledge with the world. In the show notes of every episode, including Shannon's, there's a link, a couple of clicks, take you less than a minute. Tell us what's on your mind, and we'll get you scheduled as soon as possible. And finally, Practice Care is one word, making it easy to search and therefore subscribe to. Please subscribe. We drop a new episode every week, and that's the easiest way to stay up to date on all of them. Thanks very much, and until next time.